Hello, my name is Kofi Oppong and I'm a pancreatic biliary physician at the Freeman Hospital, Newcastle upon Tyne, England. The title of this paper is Diagnostic Accuracy of Quantitative EUS Elastography for Discriminating Malignant from Benign Solid Pancreatic Masses, a prospective single-centre study. The differential diagnosis of solid pancreatic masses is a common, often challenging problem in clinical practice. EUS FNA may be time-consuming and technically demanding and has a limited sensitivity for malignancy with false negative results in 15 to 17% of patients. Elastography allows an assessment of the elasticity or firmness of a given tissue relative to that of adjacent normal tissue by measuring the strain or displacement generated in response to compression. The magnitude of the strain generated by a given tissue may reflect its histological composition. Inflammatory tissue is generally softer and therefore may show more strain. Malignant tissue is generally harder and therefore may show less strain. Elastography is an established technique in breast and thyroid ultrasound, and qualitative EUS elastography has been available for a number of years. The ratio of the elasticities of the mass to an adjacent area of normal pancreas, called the strain ratio, has been suggested as an objective and accurate method of identifying malignancy. A previous quantitative EUS elastography study utilizing strain ratio reported exceptional diagnostic performance. Sensitivity was 100%, specificity 93%, and accuracy 98%. The objective of our study was to undertake a prospective external validation of the diagnostic utility of this technique using the same protocol in a large independent cohort of patients. All procedures were performed by two experienced endosonographers, myself or my colleague Manu Nair. 104 individuals were enrolled. Patients with cholangiocarcinoma or predominantly cystic masses were excluded. We found that malignant masses had a significantly higher median strain ratio and significantly lower median mass elasticity. However, the area under ROC for detection of malignancy was 0.69 for the strain ratio and 0.72 for the mass elasticity, in keeping with the moderate diagnostic performance. The optimal strain ratio cutoff for accuracy was 4.65. This was associated with a sensitivity of 100%, overall accuracy of 86.5%, but a specificity of only 17%. The optimum cutoff derived in the previous study was 6.04. Applying this to our data gave a sensitivity of 96%, but again a very low specificity of 17% and an accuracy of 83%. Our study therefore does not replicate the outstanding results for quantitative EUS elastography previously reported. A limitation of our study was that we had relatively few patients with benign disease. Possible reasons for the modest performance of quantitative elastography include tumour necrosis may cause areas of reduced stiffness within the tumour. Chronic pancreatitis, on the other hand, may cause focal areas of increased stiffness. Certainly autoimmune pancreatitis has been reported to show a diffusely stiff elastographic pattern. In addition, the effects of tumour size, depth of tumour from the transducer, and the presence of stents on elastography measurements are unknown. In conclusion, we found the diagnostic performance of EUS elastography to be less favourable than previously reported. However, we do believe that it's a technique that holds promise, but that it's likely to supplement rather than substitute the role of pancreatic EUS FNA in the future.